This program is brought to you by Emory University.
Good morning. Welcome to the 2012 India Summit. I want to extend best wishes to each of you on behalf of my colleagues and our president, James Wagner, who's actually in India today and this week. Like him, I'm very pleased to see that the annual India Summit, which is now in its third year, has become an eagerly anticipated event among our students, our faculty, and our community. And I hope you've had an opportunity to browse the full schedule of events and programs. As Vice President and Secretary of the University, I work with Emory's Board of Trustees and Board of Visitors, the community, and several of our academic initiatives. I've been to India several times, both for my work at Emory and to visit my daughter, who's been living in Delhi while completing field work for her PhD at the University of Michigan. Some of my most meaningful travel memories are indeed from my time in India. I want to thank the Summit team for their work on developing this year's lineup of engaging sessions. The team consists of faculty from across the university, many of whom you will see named in the program today, and I'm very pleased and honored to be a part of that group. One key person on that team who is not scheduled to speak today is Charles H. Kelstadt Professor of Marketing, Jagdish Sheth. His generosity and vision have done so much to make Emory recognized for Indian studies, with the annual Sheth Lecture in Indian Studies, and also for our remarkable international Alumni Award with the Jag and Madhu Sheth Distinguished International Award. I also want to thank the Halle Institute for Global Learning, whose professional staff have managed this major event, and our co-sponsor on the India Summit, the India, China, and America Institute. This institute, the India, China, and America Institute, was founded by Professor Sheth and is now housed at Kennesaw State University. The Institute's director, Govind Hariharan, will lead tomorrow morning's session on U.S. businesses going to India. Now, I'd like to introduce Shreya Adiraju, the president of the Student Executive Committee, which has been instrumental in planning this program, and then my colleague Halle Simetko, Emory's Vice Provost for International Affairs and the director of the Halle Institute, will offer her own opening remarks. So, welcome, Shreya.
Thank you. Welcome to the 2012 India Summit. My name is Shreya Adiraju, and I'm the president of this year's India Summit Student Committee. Serving with me is Digant Kapoor, the vice president, Joyce Lee, our chair of marketing and PR, Atish Chabria, our treasurer, and Rahul Sharma, our chief of staff. 3 years ago, a group of students, including myself, came together with a unified and unique vision. That vision was to bring forth and create dialogue about the role of India in the global community, share discussion and hear insights from experts in all fields, and most importantly, encourage others, students, professionals, academics, and all individuals to join us in this intellectual mission. Today, it is clear that that vision is happening. What started as a lion-sized dream, coupled with a small but opportunistic start, has turned into one of Emory University and the Halle Institute's most prized events. We excitedly look forward to hearing from our respected guests and speakers, and sincerely thank them for all of their time and commitment to our summit. So without further ado, thank you for your time, and please enjoy. Thanks.
Thank you, Shreya. My name is Halle Simetko, and I have the pleasure of serving as director of the Halle Institute for Global Learning. We all know this build-up for the third annual India Summit has been great, and we have a full capacity for every session. And so we're excited about that and about the opportunities that come with the introduction of the new ambassador, Nirupama Rao, who will be here later today for the keynote. And the embassy, I wanted to mention, is one of our sponsors of this event, and we're delighted that Atlanta is now home to a new consulate. The Indian Consulate General will be here later today with the ambassador. Well, I want to thank our staff and our students for all their dedicated work to bring this event together. And I want to also thank our co-sponsor, the India-China-America Institute. Traveling to India, I think we would all agree, one comes away with lasting impressions. And if there's one lasting impression to come away from, I think, in the next 2 days, it will be that India-U.S. relations are, and ties are stronger than ever. And we'll see examples of that from the summit. And the summit's going to feature politics and diplomacy, business, technology, healthcare, and the arts. And today's media environment means that we'll be seeing this around the world. So it really is a global summit. We're webcast live, and we're going to be also online later for classroom use. So there will be a video of the entire summit. Alongside the summit, you might be interested to know that this year at Emory we launched a course, an interdisciplinary course that's sponsored by the Halle Institute for Global Learning for undergraduates, and it's called India Today, Economics, Politics, Innovation, and Sustainability. And just like the summit, the course filled up very quickly, and so we have a number of students from the course throughout the day with us. The course draws on our faculty in the college and in Goizueta Business School, and it's the chairperson of economics, Elena Pesavento, was behind the plan for the course. And so we're bringing together a great group of people in a course that brings you from the macroeconomic picture of India, provided by Jeff Rosenzweig and Jagdish Sheth, to a critical analysis of the Moor's Last Sigh with Deepak Abari in the English department and Salman Rushdie coming to class next week. So I wanted to just remind you that the summit has really created new opportunities for students to study India, and we are doing that right now. So with no further ado, I would like to start our next panel by saying that the main cross-cutting theme of the summit is innovation, and probably one of the most interesting innovations recently for us to learn about, since it's been happening for some time, but we're learning about it here in the U.S. more recently, is medical tourism in India. And I want to thank Manoj Jain, who is responsible for organizing the first panel session with a number of innovative speakers who he will introduce. Manoj is on faculty at the Rollins School of Public Health. He's also a writer. Many of you may have read his work in the Washington Post, the New York Times, the Hindustan Times, the Times of India, and a number of other newspapers. And he's also the president, or the head of, the medical director, excuse me, of Tennessee's Quality Improvement Organizations. So with that, I'd like to thank Manoj, and let us start. Thank you.
Thank you. Thank you, Holly, and welcome everyone, and good morning. And I should also say good evening, because we have a number of people in India who are joining us, and it is about 8:30, 8 o'clock in the evening in India, and first time we're sort of live webcasting to India as well. As Holly said, I'm a physician. I'm an infectious disease doctor. I live in Memphis, and I'm a faculty here at Emory. I also write quite regularly for the Washington Post, and I had done a piece on medical tourism which caught an attention of a lot of people, enough people, including Holly, for us to put together a session today to explore this topic further. I want to begin with a story, and it's about my father, and I guess if I'm talking about my father, I have to also talk about my mother, otherwise she'll be upset. And so it was a couple of years ago when my dad had this terrible toothache. It was just paining him horribly, and he went to his dentist in Boston. They live in Boston, and the dentist charged him a couple of $100 and said, you know what, looks like you've got a root canal, and you'll need a crown. And my dad, knowing our family traits, asked him how much it would cost. He's really cheap. And the dentist told him, $2,000, $3,000. And my dad said, I think I can bear the pain. I'm going to India. I'm going to India in a couple of months, and that's what he did. So my dad's family trait is that he's cheap, and it comes from my grandfather. My grandfather was very money conscious. He wouldn't let my grandmother go to the movies because it would cost too much money. So he went to India, and he had the procedure done for $200. So, well, my mom is also in this whole picture. She wanted to get into the act. She didn't have any active dental problems, but she saw what my dad had gotten done, and so my mom, the family trait is that when she sees a bargain, she's a bargain hunter. She sees a bargain, she goes for it, and between her teeth there was a little gap, and even after so many years, she said, you know what, I'm going to get that fixed. She saved about $3,000 and had the gap between her teeth, the teeth replaced and fixed. Now, all of that is very interesting as an anecdote, but you know what? Behind it, there's an entire industry that is there. And according to Deloitte consulting firm, 875,000 Americans, like my parents, went to various countries for medical tourism in 2010. Now, it was not just for dental work, though. It was for things such as elective hip surgery and for bypass surgery. Now, my parents won't be joining us for the conversation today. They're watching me and us from India on Skype and the web streaming. But who will be joining us is one of those 875,000 people who did go to India and had a bypass surgery. And Willie Bearden is one of our speakers today, and he will share his experience. Honestly, I had not given medical tourism much of a thought myself until I went to Bangalore, India, at Narayana Hrudalaya. This is a hospital founded by Devi Shetty in Bangalore. It's an enormous medical complex. And also joining us, if technology permits, through Skype, will be Dr. Devi Shetty later on in the conversation. There, they can do bypass surgery for a tenth of the cost, between $2,000 to $5,000, compared to what we know it costs in America. But the issue that we have when we go and look at medical tourism, and what my parents had when they were getting dental work, was this: the quality. Is the quality of care that they receive appropriate or not? That's the biggest fear. The cost can be one of the motivators, but quality is one of the major issues. To help us better understand that issue, Yehuda Dror, who is the president of the healthcare division of DNV, a risk management institute, was also with us to talk about that. And so we begin our conversation today, and just to give you a scope, I was Googling medical tourism today to see if there was anything new. And I saw this Times of India piece that had just come out, which said this: medical tourism took the state of Kerala was about $333 million in 2006. And within the next 5 years, it's to reach about $2 billion just to the state of Kerala. Now, imagine that. Could medical tourism be the next IT, the information technology outsourcing boom that one has seen? We don't know. There are many obstacles as well as opportunities that are there. Yet, it is worth a deeper look and a conversation. And so, to look at the topic of medical tourism from a patient perspective, from a hospital accreditation perspective, and from a hospital in India's perspective, we have 3 speakers and our panelists. And so what I like to do is to ask the panelists to come up, and I will introduce them, ask them to speak for about 15 to 20 minutes, and we will engage in conversation while we're after their talk. We can do a question or two, and then at the end, we'll keep it quite engaged with the conversation. So I'd like to begin with William Bearden. Willie is an author and a filmmaker. His documentaries have been on PBS. He is from Rolling Fork, Mississippi, and I got to know him on occasions when my piece came out in the local paper. Then the local paper in Memphis knew about his experience, and so Willie has had a phenomenal experience that he will share with us, and we'll begin with that. Willie?
Thank you. It's a pleasure for me to be here today. It has been quite a journey I've had in the past few years. I am a filmmaker and a writer by trade. I've been very fortunate in the sense that I've had my own company since 1988. I started off as a film editor many years ago in the late 70s, and I was an account exec for a film company in Memphis, and I traveled around the country and kind of learned this business and started my own company in the late 80s and did mainly corporate video and things like that. And in the mid-90s, I started, I had this crisis, and I thought, you know, I've done so much work for FedEx and International Paper and Fred's Dollar Stores and just all of these corporate clients. And I thought, you know, when I'm gone 20 years, are my children going to be sitting around saying, you know, Dad did some of his best writing on that spill cleanup video for FedEx? Or no, I think the shelf maintenance and signing video for Fred's Dollar Stores. And I thought, is that going to be my legacy here? So I really kind of stopped and really started thinking about that. And I started making documentary films. I thought I'm a reader, I was an amateur historian at the time, and I felt like I had a point of view, and I wanted to help to popularize the story of the South and Memphis and the Delta. So I started doing some documentary work. I did it out of my own pocket. Very quickly, I was asked to do museum work. I've done lots of museum pieces. I've done lots of things that have been on regional and local PBS. So I've been very fortunate in that. Along with that, I've started going to Horn Island, which is a barrier island off the Mississippi Gulf Coast. It's where some of you may know the artist Walter Anderson. Walter Anderson went to Horn Island and spent, you know, weeks and weeks there for 20 to 25 years, and became a wonderfully, a really well-known artist. So I started going with the College of Art back in 1997. I was asked to go along with them. They take students down there for an 8-day experience, camping in the sand, no running water, no electricity. It's a very tough thing. So I've been going for many years. Well, about 5 years ago, 4 years ago, I was down there, and the boat that picks us up came to the other side of the island. And so we had to haul all of our ice chests and tents and everything across the island, walking in the sand. And I like that. But I made 13 trips across the island in a couple of hours, and I had this feeling in my chest. Something was wrong. It was like I was very winded, like if you've run a long way or run up, 5 flights of stairs or something. And I knew what being winded was like, but this was different. I really didn't pay much attention to it. I was okay after a while. After that, gradually, I started having problems. I would walk around the block, and I'd get halfway around the block, and I'd think, wow, I'm having some tightness in my chest. And so I saw that I was starting to have some health problems. I had lost my health insurance. When you decide to be an artist, when you decide to be a filmmaker, you make some very conscious decisions, and I knew I was going to have to make some of these decisions. And I had health care until about 4 years ago. And my health care, due to some problems in my family with my wife and my daughter, kept inching up, and it went from $1,200 a month to $1,800 a month, and I simply couldn't afford it anymore. Maybe I could have afforded it because I make good money, but the prospect of that, it was hard to do that. So I thought, you know what? How do we use our health care anyway? We go to the minor med center, we spend $200, they cure you of the flu. We go to the pharmacy, we get whatever we need. So do I need anything? What am I gambling with here? And what I was gambling with was a catastrophic accident or an illness. And I thought, well, I'm just going to have to gamble. Well, about that time is when I started having the heart problems. They weren't bad at first, and I learned to adapt, really. I went for 3 years like that, but finally I got to where when I would see a flight of stairs, I'd go, oh, God. Or if there was a hill, luckily in Memphis there are no hills, but I remember I was out in Long Beach, California, and my hotel was here, and the place where I was producing a show was down the hill. And every day when I would have to walk those 3 blocks up the hill, I'd have to stop 3 or 4 times. So I knew I had to do something. So I was talking to a doctor friend of mine one day, told him that I was having some problems, some chest pains. He freaked out, said, you've got to go see this heart guy. So I go over to see the heart guy. He takes me right in. I told him on the front end, I said, listen, you've got to understand, I do not have health insurance. And he looked at me like, you idiot. He said, well, you've come to me. I have to treat you. I said, you can try that on somebody else. You can forget you ever saw me, really. I just want to know what is likely wrong with me. He said, well, what is likely wrong with you is you have clogged arteries. I said, okay, and then what do we need to do here? He said, well, I would have to do a heart catheterization on you to see what's wrong, to see if you are indeed blocked. He says, we go up through your femoral artery, shoot the dye in, we take a look on video and see if you're blocked. I said, okay, what does that cost? He said, I'm not sure. And I'm thinking, is this a part-time job you have here? Because I know, as a writer and filmmaker, I know what everything costs, I know what an hour of editing costs. I know if I have to go to get voiceover work done, what that costs. I know what cameras cost. I know what everything in my industry costs. And I'm thinking, you're a heart surgeon. You're much smarter than I am. You should know this. But he didn't know. He had to say, because there's no price on this. Your price is different than yours, and your price is different than yours and different from mine. It's all what you got and what they can get. So he sent his nurse out. She came back and said, well, Baptist Hospital here, they say it's going to be about $8,000. I said, okay. I said, how much are you to the doctor? He said, well, I'll be about $2,500. I said, fine, I got that. I pay you that. It's not like I'm broke. I'm not indigent here. Okay, $12,000. I said, but what does that buy me? He said, well, I'll tell you what's wrong with you. I said, okay, all right. I said, okay, what's likely then to be what you would have to do to me? He said, well, we'd probably just put stents in your arteries. And we may have to put several stents in your arteries to open up the flow, and you'll be okay. I said, okay, how much does that cost? Again, he looked at me like, okay, I wish he hadn't asked me that. So he sent the nurse out again. She came back. She said $60,000 to $80,000. And I said, well, I'm out. And he said, what do you mean? I said, I'm out. He said, well, you can't be out. You might be out. I said, I can't do that. I don't have that kind of money. He said, well, and you may need bypass surgery. I said, well, how much is that? And so yet again, she goes back. She said, well, between $150,000 and $300,000. I said, okay, I'm really out now. So I started thinking, okay, I have this problem. What am I going to do? At least I need some stents. I know that. So the doctor said, well, he said, listen, all you have to do, you show up to the emergency room showing these symptoms, and we have to treat you. I said, yeah, that's fine for you, but then you chase me for 2 years, and you sue me, and I have to go bankrupt, and I have a building in downtown Memphis. I will lose that building, likely lose my house and my car. And you know what? I'm 60 years old, and I'm not going to lose everything I've worked so hard for. I'm simply not going to do that. That's unacceptable. So at that point, I forgot about this doctor, and he said, well, come, I need to do some tests. I said, I'll be right back. So I just, at that point, I forgot about the American medical system because I thought, I'm not going to be mad. What I'm going to be is proactive. I'm going to find something. I think there have to be some other answers. So I, as a documentary filmmaker, what you do, and there's no mystery about this, you write term papers for a living. That's all you do. On a certain date, you have to have this thing ready for television. But before that, you have to go to the library and do a lot of reading. You have to do a lot of research. You have to talk to a lot of people. And on that certain date, you have to hand that term paper in. So I approached this exactly like I would approach a documentary film. And in 2 weeks, folks, I was an expert on medical tourism. I saw the countries that most people went to, Belgium, Thailand, Mexico, Costa Rica, and India. And my criteria was, because I talked to somebody, they said, well, you can go down to Mexico. I said, well, okay, yeah, and, you know, cost about the same. I said, well, you know, where do you go? They said, go to Tijuana. And I said, no, I'm sorry. I know that's probably not the way I should approach this, but I'm not going to Tijuana. I'm sorry, to get any kind of, some stents put in. So I thought, well, where haven't I been? I had never been to India. So with a large amount of hubris, I thought, okay, I'm going to go over to India. I'm going to spend a couple of days in the hospital. They're going to put these stents in me, and I'm going to be okay. I'm going to jump on a train. I want to go to Calcutta. I want to go everywhere. I'm going to take the train all around India, so I'll have a nice vacation. Well, I started looking around, and I thought, okay, where do I go? So just looking on the internet, I saw that Fortis hospitals had a pretty robust system of medical tourism. That people were going over there. I saw a couple of testimonials that people had done, video testimonials, and I thought, okay. And you can say anything on the internet. You can say anything. And so I thought, okay, I'm going to have to just assume that some of this stuff is correct. And maybe not all of it, but I'm going to assume that some of it is correct. So I went to their website. They said, take a look at our doctors. So I went to the heart doctors, and I read every one of them. I went to every one of them, and I found this guy. And his name was Dr. Vivek Javali, and he had been the president of the India Heart Surgeons group, and had done lots of innovations in this non-intubated surgery where you are actually awake. Now, I didn't want to be awake if I had surgery, but I thought, you know, here's a guy who's passionate about what he's doing, so this is the guy I want to talk to. So I emailed him. A day later, got an email back. Mr. Bearden, we do this every day. We have Americans in our hospital every day. So I said, could you send me a picture of the room I would be in? I just wanted to see. You know, I'm thinking, okay, what is this going to look? What's the hospital going to look like? They sent me a picture. Beautiful room. Looks like a hotel room. I'm thinking, okay, that's good. I'm hoping this is going to be the room I'm going to be in. I'm going on faith here again. I was very busy at the time, and all this was happening in the fall of 2010. I was very busy. I had agreed to do this live from Beale Street broadcast for the public TV station there, and so I knew I was going to be busy through the first of the year. So I thought, okay, I'll go over mid-January. So I kept talking to them. I kept asking them all these questions, trying almost for some of those gotcha kind of things. You know, let me ask the right question, and maybe they won't have an answer. I'll go, aha, this is a scam. This is not going to work. I never got that. What I found is that I started having a relationship with these people just over email, and I thought, you know what, this is going to be fine. Now, I will tell you that I'm an optimist, and I have always approached the world as if everybody's going to like me, I'm going to like everybody, and everything's going to be pretty cool. And you know what happens to me in my 61 years? Everyone pretty much likes me. I like everybody, and everything's cool, okay? So I went on that assumption. So I told them I thought I was going to have stents, and they said, well, maybe. I'm sure they knew probably more than I did what I was really going to have. I wound up leaving the U.S. on January 10th, 2011. Flew over to Bangalore. Long way to go, folks. Not just around the corner. Long, long way to go. Long way to go. I flew to Chicago, missed my Paris connection, had to spend the night in Chicago, had to fly to Toronto, Paris, into Bangalore. Long way, you know. But it's winter, snowing, you know what happens in Chicago. So I got there, the people picked me up, the folks from the hospital picked me up, took me in, checked me into my room in the hospital. It was a beautiful room. Everybody was very nice. Everybody spoke English because my family was going, oh, people won't be able to speak. And I said, you know, believe me, they're going to be able to speak better English than I am Hindi. You know, I guarantee you that. So I got there, and I just immediately felt like these people cared about me. And I've been in the hospital in the U.S. several times, and I had not had that level of like human, you know, relationship. You know, these people do care about me, and I thought, you know what, India is a very mind-body place, and I'm glad I'm here. You know, it was something I didn't know till I got there, but I thought, I'm really lucky I'm here. So, got there the next day, we did the heart catheterization, and I'm laying there on the table, have the thing up my femoral artery, and, you know, it's like, oh, God, you know, I'm watching the screen, and I'm thinking, oh, this doesn't look good. I'm not a doctor, but this doesn't look good. So the doctor says, oh, we got a problem here. Said, all 4 of your coronary arteries are blocked 70 to 90%. And I thought, oh, boy. So I said, okay, what do we do? He said, we're going to have to do bypass surgery. And at that moment, the hubris flew out the window. I thought, what was I thinking here? I came over by myself. What was I thinking? And I thought, okay, I got to really think about this. So when you have this angiogram, they call it, when they take this thing out of your femoral artery, somebody has to literally stand on that for hours to make it stop bleeding because you will die. And my nurse was sitting there. She's my friend on Facebook, I'll say that. We talked, but, you know, so you have to lie completely still for 6 hours. 6 hours. My back was hurting, and I started thinking, I thought, okay, when the 6 hours is up, I'm going to get up, I'm going to put my clothes on, and leave. Because I don't think I could do this. So the 6 hours were up. And Dr. Javali came to my room, and that was the first time I had met him. And he said, let's sit down and talk. And we sat down and talked for probably 45 minutes. And we talked about lots of things, you know, not just about my heart, not just about healthcare. We talked about lots of things. He said, I can see you're a little nervous about this. I said, yeah. He said, let me tell you. He said, you're a healthy guy. You're not diabetic. You don't have real high blood pressure, so you don't have real high cholesterol. He said, you've got clogged arteries. I can fix that. He said, you've got a great artery in your forearm that I can take, and I can make those grafts. He said, I can do that. And I thought, man, I bet you can. I started saying, let's do it right now. So I just had this kind of ultimate faith in him just by the way he dealt with me, somebody he had never met before. And I think I keep going back to that humanness that I felt there in India that made all the difference in the world for me. So this was on a Friday. He said, let's do this Monday morning. I said, okay, fine. Well, another good thing had happened. My friend, and now you got to follow this, my friend Barry, his best friend Elton's wife's sister lived in Bangalore. And they had I had never met these people at all. But they had called and said, hey, Willie's going to be there, go see him. This woman, her husband was working for a high-tech company over there. She was an angel to me. She was at the hospital every day. She came over on Friday and met me after I had the heart catheterization. Saturday, the driver picked us up. We went to several Hindu temples. We went to the Russell Marketplace. We went all over the place. So on Saturday afternoon and Sunday afternoon, I got to go around Bangalore and see some of Bangalore. In the mornings, they would do tests on me, and they would take me down for a test, and boom, done and done and done. So it was very quick, very efficient. Monday morning, I had the surgery. It was about a 5-hour surgery. They say I did okay. I woke up in ICU, and my friend was sitting there right beside me, and like I say, she was there every day. And immediately, I felt better. I mean, obviously, they crack your chest open, and that hurts. That really hurts, especially when you have to sneeze or cough. That's the one thing that really got me, and it got so bad the first few weeks that I would just start laughing hysterically if I had to sneeze, because I knew it was going to feel like somebody hit me with a baseball bat, and that was just my response. Oh, this is going to hurt. Ow. But other than that, it was, I don't want to say it was no big deal, because it was a big deal, but it wasn't that big a deal. Got back to my room, my nurses were there, the people I had known for the last few days. They talked to me, they were interested in what was going on with me. I decided that I really needed to eat and get strong, and that I needed to exercise, and so I thought, whatever they tell me to do, I'm going to triple it. I'm going to, if they need me to walk down to the nurses' station once every 2 hours, I'm going to walk down there 3 times every 2 hours. Sure enough, 2 days later, I'm walking around, I'm walking all over the floor of the hospital. The next day, I put my blue jeans and T-shirt on, and the nurse is going, no, you can't do that. You've got to have your gown on. I said, I'm done with the gown and the pajamas. I'm better, okay? So they call my doctor. He won't wear the pajamas. He said he doesn't need to wear the pajamas anymore. Let him do what he wants to. I walked upstairs, and I just started feeling better and better and better every day. But I saw Dr. Javali every day, and he had told me, he said, listen, he said, you're as important in this process as I am. He said, your attitude, the way you approach life is as important as what I can do with my hands inside your body. And I just understood that, and I just felt so good about it. So I got better. I went to a hotel. I stayed in a hotel for 5 days in Bangalore, fairly close to the hospital, a 15, 20-minute cab ride from the hospital. Great hotel. I had a wonderful vegetarian restaurant. And finally, Dr. Javali said, well, in fact, we had a meeting one day, and he said, today we're going to talk about this much medical stuff and this much film stuff. He had Googled me, and they had actually asked me to bring a couple of my films, my DVDs, and I had given some to him several days earlier. He had watched the DVD, so we had a long discussion on this film I had made, and it was a very interesting discussion. He's a very smart man and very insightful, and so I felt like I'm really getting better now if we can kind of talk a little bit of medicine and go on and talk about things in our own worlds. So I came back, flew back to Memphis. That was a very tough thing, just having to, 36 hours door to door, long flight, from, had to fly Bangalore, Delhi, Amsterdam, Memphis. Just, those legs of the flight are 9.5, 10 hours. Just a long way. It just takes a long time. Got back, went to my friend is a nurse practitioner. He's been taking care of me. And he said, man, everything looks great. You look great, I said, I feel great. I feel like, and in fact, Dr. Javali told me, he said, I was good for another 30 years, so I'm going to hold him to that. So I hope I can come back when I'm 90 and say, well, here I am. I'll be gone soon, but here I am at 90. It was a very, very positive experience. I was looking at having to spend between what they quoted me, $150,000 and $300,000. I'll go on the record here today as saying I do not have that money. There's no way I could have come up with that money. When I went to India, everything they did for me, 11 days in the hospital, every test known to man, and I made exhaustive tests, surgery, everything, all my medications, everything, $9,000. $9,000. Yeah. Paid for it on my debit card. Now, let me say that again. $9,000. And I kept thinking, what's wrong here? If it was $300,000 here and $200,000 there, I might still say that. But $9,000, I still don't understand, and it's probably not my place to understand, but I can tell you this. At the point when you stop thinking about the macro picture of what's wrong with our health care and all that, and you start thinking about, here I'm a guy, I'd been working on a novel for a while, I had a few other films working, I was doing all of these things, and I thought, this could all be over because you know what? I could be absent here very soon if I don't get this done. And the doctor told me that I would have had a heart attack and I would have died some months after that. So, totally forgot what's wrong with the American healthcare system. Don't want to argue that. Don't really care about that. To know that there is somewhere that there's hope for people who need this on an individual basis. We can argue this stuff all day long, but when it comes to this, real people that you know who don't have health insurance for whatever reason, and believe me, there are a million reasons why you can't have health insurance or why things, get away from you. And it's not just people who don't want to work, and it's not just people who don't have any money. There are lots of reasons. And so I saw an opportunity to go somewhere and to be healed, and I was healed. I feel great. I could walk from here to Rome, Georgia, and I don't even know how far that is, but and not have to stop but a couple of times probably. I feel great in that. So that's kind of my story, and I really appreciate you having me here today, because every time I've told these stories, I told the story to our newspaper in Memphis, and I've had this conversation going with two different people now, and one of the guys and his wife are going to Bangalore in a few weeks, and they're going to. This guy has to have valve replacement surgery, and this has been something that's kind of genetically. His father died very early, same thing. His brother died, same thing, and so he's going to go over there, and hopefully he will be healed. I am pleased to say I'm going to be able to pick up some of their hotel when they're over there. So, it's just kind of my gift, I hope, that keeps on giving. So maybe some of that money I saved, that not having to pay $300,000, I can help some other people to make their journey a little lighter. So thank you very much.
Really, thank you so much. I know it was initially difficult to share that story with a lot of people, and we all really appreciate you sharing. I think what you're saying is very telling for our healthcare system in America as much as it is for the healthcare system in India. The cost aspects and the lack of insurance, I think there are 40 million reasons why people don't have insurance, each person having a different reason. You talk about the human relationships and how critically important they are and how they've worked well for you. And you talk about teamwork, what Dr. Jawali said, that you are as important as I am. And often I know as an infectious disease doctor, I was seeing patients yesterday, I'll see them tomorrow, and we tend to forget that. And I'm so glad that you've brought those issues to the forefront. Now we want to take another perspective. One of the fears that people have when they travel abroad for healthcare is the quality. Where does India stand on many of these quality issues? It's difficult to tell. To help us explore this issue, what we're going to talk about is the quality aspect, and one of the key people who's looking in and working in this field is Yehuda Dror. Yehuda is the president of DNV Healthcare. And if you are not aware of what DNV is, I wasn't very much aware of it until I saw their logo, and I've seen their logo everywhere. It's a risk management institute looking after safeguarding life, property, and it's been in place since 1864 and employs 10,000 people, 300 offices in 100 countries. Yehuda has been with them for over 30 years and has been looking after the quality aspects as well. He has a master's from MIT, MBA from University of Houston, and bachelor's from Texas A&M. Yehuda, we're so delighted you're here. Thank you.
Click on this one. How do I get? Well, until my presentation comes on, my name is Yehuda. I lived for 30 years about in Texas. That's why my East Texas accent. So for those of you who are a bit confused, and I got into healthcare because I read about 8 years ago an article that healthcare is going to a U.S. hospital is 7 times more risky than skydiving. And since I'm an avid skydiver, I said, well, maybe I can do something with the healthcare rather than increasing the risk in skydiving. By the way, skydivers are a very strange breed. I'm jumping with a group of skydivers over 60, and it's called SOS. So that just gives you an idea about the thought process. Well, good morning to you. I'm very pleased to be here, and good evening to our audience in India. I will try to present to you exactly this concept of perception and how accreditation can and should work in reducing the anxiety that people have either going abroad or even going to U.S. hospitals. We are in the accreditation field. I don't know how many of you understand or know accreditation, but in the U.S., accreditation was mandated by the Center for Medicare and Medicaid, so a hospital that wants to get reimbursed for its Medicare and Medicaid patient will have to be accredited. There was only one game in town, and for the last 45 years, and about 3 years ago, we made history by getting the first break into this by being approved by the U.S. government. And what we tried from the beginning is to show that there is a different way to accreditation that makes sense. And by the way, being an engineer, I'm the only engineer in the organization, everybody is from healthcare. It gives me a certain perception or a certain perspective, I would say, about healthcare. There are many, many things that really surprise me. Maybe they shouldn't. But healthcare is one of those industries that maybe the last bastions of industry that believes that if it is not invented here, it's not good. So what we try to do is try to bring to the fray a concept that may work and learn from other industry. And being in the business for 150 years, we know something about risk management. I think that Manoj mentioned that we are, in 100 countries, 3,000 or 9,000 employees. In India, we have been actually since 1972. We have 14 offices over there and about 250 people. And I like to consider ourselves as, like Manoj said, as the largest company that people don't know about. So I'm going to give you some indication about this. So with that, as I mentioned, the presentation will go very quickly about who is DNV, talk about global challenges with healthcare, talk about patient mobility, because this is what we heard from Willie, and then how does accreditation work into this concept, and show you some testimonials from the field. DNV is everywhere. I mean, we safeguard life, property, and the environment, 300 offices, 100 countries. Employees, we are an independent foundation, and I'd like to call ourselves a tax-paying foundation, because we decided we are not charitable, we are self-supported. And one of the things that we did is that we decided that because we are in 100 countries, we have to, where we employ local employees, we have to have the social responsibility and the citizen responsibility. When it comes to our core competence, I mentioned the transfer of competence, is that we started in maritime, went to offshore, but then we are very, very active in all this field that you see. And with one important concept, it's not about inspecting, it's not about telling you exactly how to do that, but learning how to manage risk. And I can tell you, when I got back from, I lived for 6 years in Europe, and we did a lot of risk management in hospitals over there. And I came back to the US, and one of the first things that we asked about risk, every hospital said, oh, we have a risk committee. So we said, okay, let's take a look at this. What is the risk committee do? And I can tell you that from my vernacular, and I hope I'm not upsetting anybody, that was at best a bad accident investigation. Not even a good one, but a bad accident investigation, because it was all looking in retrospect. And I'm talking about 2001, 2002. There's no question that the U.S. Medical sector or healthcare sector did a lot of strides in understanding risk, but there's still confusion between hazard and risk. And the more understanding you have about that the hazard is everywhere, and then if you understand the likelihood and consequence of this hazard, then you get the risk number. This is what we try to also input into the accreditation concept. This is for our Indian audience, showing our strength in India, where we have about 9,000 certificates, which means evaluation of all these organizations. We are very strong in medical devices, in aviation, in defense, and IT definitely, and food, of course, as well as in maritime and offshore. We have been involved with India on biorisk in trying to look at in the effort of the polio eradication. We have established in this process with the Mumbai work in the Mumbai laboratory the first standard, which you see on the left, the bottom of the left-hand corner, the first standard for high-risk laboratories like CDC here and all the CDCs around the world. So we work with NHS, we work with the WHO, and of course in the US I mentioned our break into accreditation. So one of the things that Manoj said is health tourism or healthcare in general is all about perception, and perception is reality. What we learn is that, and this is very, very interesting, the problems in healthcare around the world are absolutely global. It's the same problem everywhere. The issue is that the solutions are always local. And they're always local, and they will be local as far as we know, because healthcare budget is one of the biggest ticket item budget for every nation. And I don't think that any nation will ever relinquish it in favor of one. So, because of it, you have localized solutions to a global problem. Now, what is going to be done with this? That's something that we cannot, it's not for us to give the answer, but we can only give some of the tools that would work. At the same time, you have issues of hospital-acquired infection risk, and it's trying to be countered by the never events that, for instance, CMS introduced. But medical tourism, without any question, is a direct function of this kind of patient trust. And when it is high, you will go there. When it is low, you will not go there. And to show this, I wanted to give you a perspective from Europe, which is very, very telling. A study was done in 2010 about in 27 European countries. And this is the same healthcare, almost about the same governance of healthcare system, public, universal health, et cetera, et cetera. And one of the questions was, how likely do you think you would be harmed if you go to a hospital in your own country? And the results are shocking. Shocking not because what people say, but the diversity. In Greece, 83% of the people believe that they will be harmed. Some of them believe they will be very harmed. On the other hand, in Austria, only about 19% believe that they will be harmed. But when you have this kind of distribution, it shows one thing, that the perception about what's going on in the country, regardless of what is the governance, is controlling this. In this, the next slide, just some examples. Of course, everybody knows about the hospital-acquired infection. It's the same picture all over the world that fits into the theme that problems are global. And whether it is 2% more, 3% more is not interesting. It does work itself, or it does affect healthcare tourism to a very large extent. And the EU cross-border, for instance, is only one aspect of health tourism. It's not called health tourism, but come 2014, European citizens will be able to go from one country to another and get treated, and their indigenous country will pay for this. So what are the rules for this? And this is where international accreditation comes in, or accreditation in general. You have many, many countries where accreditation exists. I just wanted to give you one picture about what we think accreditation should do. In that, accreditation has to work to the perception, which means somebody with authority has approved the standard, and it is being accepted in many places in the world. Whether it is international, whether it is local, it really does not make that much of a difference, but it has to be rooted in evidence-based, which means the outcomes must be the rule whether this accreditation works or not. The way, just one example, in India we have, at this point in time, bearing in mind that we are the new kid on the block in accreditation, we have one hospital that's Asian Heart. In Brazil, the reason why I brought it in Brazil is that I think that the experience in Brazil could actually be a good blueprint or good template for India, where they have a local accreditation which is a multi-tier, which means not every hospital will go to the highest tier, and then once they get to the highest level, they will have international accreditation. Slovenia is using, for instance, the international accreditation as a means to show that all its hospitals could care to the Germans, the Austrians, the British that will come there, and they chose this. So every place chooses a different way. What is the core in accreditation, at least the way that we looked at, is, for instance, for us, the main theme or the main guideline or the rules is, of course, the CMS condition of participation. This is our law. This is what we, and the same thing would be in India. You may have local laws. Then instead of going to a very prescriptive how-to, what we are doing is basically basing it on objectives. You have to have objectives, show your objective, and work to show that your objective meet your intent. You sort of anchor them with a system, a quality management system, and then you can have best practices. Now, one of the things that is very different is we do not try to have one size fits all, because in healthcare, maybe more important than any other sector, we have not seen that one size fits all works in any sector, let alone in healthcare. Because by definition, if you and I go to have the same procedure, our history and physical is different, we are a variable. And to have a one size fits all, in our opinion, doesn't work. So you have to show it, and it does work, or it does encourage, not just encourage, require you to think about innovation, innovative approach to this. I will leave you the slide, so I'm not going to go into each one, but this is basically the main difference in our accreditation. It is an annual event, and when I say event, an annual visit is one of the surest guarantees that you are not going to prepare for an exam, because every 12 months comes exactly every 12 months, and time flies very, very quickly, so you do not have time to prepare for an exam. You do it because it's something that works for you. We introduced a ISO 9000, for those of you who are not familiar, as a basic for a sustainable management system, a quality management system, because we believe that without a quality management system, you will not have what you need to have. If you look at the concept, the quality management system, in essence, is the skeleton that we are looking at. It's a generic system that says this is what is a good quality management is. It does not tell you how to. And then we have the accreditation, which speak to the condition of participation. They are what we call the beef, the muscle, the sinew that makes it happen. And the most important thing is that you have to look at it as one standard, as one system. Because the moment that you diverge, then it becomes a divergent program. Then you do things for us, you do things for the standard instead of doing things for yourself. Just quickly, some of the chapters, they follow the condition of participation. We enhance it with quality management system, medical staff requirement, primarily credentialing, and of course physical environment, because we do not believe that you can have safe patients with an unsafe physical environment. I'm not going to take you to this, but in essence we are looking at a crosswalk between the regulations, the accreditation standard, and the ISO 9000. The more we understand it, the better it is. The team that we send is usually clinical surveyors, generalist surveyors that come all from the hospital, and of course physical environment. And just in this process, as you see, it's an annual survey. What we try to make sure is there are no life-threatening findings. If there are, it's a jeopardy. It's called a jeopardy level condition, and maybe as an example of what is a jeopardy level condition, this is a real finding from a real hospital. When we came in and we found that the ceilings were covered with mold, and as far as I'm concerned, not being a physician, if you have mold, infection control goes down the tube, or goes up in smoke, or goes up in mold, whatever you want. So in that case, the hospital has to do something before we even come back and look at them. So that's as an important, how important are the issues. But normally, when you have findings, they are related to whether they're systemic or non-systemic. And then our main way of dealing with this is rooted in the fact that findings are good, actually. Whether Edison said 10,000 or 700 or 1,000 depends on the source in Wikipedia that gives this quote. But in essence, findings are good, because what you want us to do, we are not the hospital's policeman. We are the one that may find something that you did not think about. And in healthcare, what you don't know really kills, more than any other areas. So if we find something that you did not know, or steered you to look at something that you don't find, that's good. And that's why we deal with this, because we do not have any points or tipping point to say if you have 10 of those or 20 of those, you're dead in the water and we cannot do anything with you. So we give you time to fix it and so forth and so on. Just an example of the certificate to Asian Heart. And what we have seen is that it really having these two systems in one, and this is an example from a hospital in the Czech Republic, is that it does help them, even if they had before ISO 9000. I mean, all of a sudden they see that something is working, to have process improvement, to have accountability and innovation. It is an innovative approach, and what our claim to fame is basically with the hospitals that we have. In the US, we have now 265 hospitals. That's a bit old. And all of them are looking at a cultural change towards accreditation. And not that accreditation is the thing that is going to improve everything, but because accreditation was so much in the backdrop, you had to do things for accreditation. You forgot what you need to do for yourself. We tried to change it. So with that, the conclusion is that healthcare problems are indeed global. Solutions are always local, they will not, and I don't think that they will change. Accreditation can and should work as one of the tools that the hospital have to improve. And the last but not least is infection control, and this is where the managing risk comes in place. Infection control is not just washing hands. Everybody thinks, okay, we wash hands and everything is going to be hunky-dory. But it's not, because one of the problems in infection control is trying to understand where is the risk. And what we have seen is hospitals that, for instance, take the whole architecture and look at how patient flow is, fare much better in this, because if you design the patient flow well, then the nurse or the physician that are in one place and being beeped in 5 other places will not have to run to different areas, and in that process will forget to wash hands, or do not have time to wash hands. It's not that people do not want to do the job. It just, you do not give them the tools to do them. So look at the managing risk, look at how, or the risk that is associated with infection or with anything else. If you design your process well, you will have a good process or a good outcome. And if the outcome is not good, it means that something else is not good, and then you have to look for it. So, with that in mind, thank you very much. I appreciate it, and we will have another proceedings. Thank you.
So, Yehuda, thank you. And one of the take-home messages from me, from what you're talking about, is if India wants to leapfrog in the area of quality, and medical tourism be part of it, what it needs to do is not just accreditation, which is what most hospitals, 95% of the hospitals in America are doing. Accreditation just means a seal that you've done a level of quality. What DNV is doing is accreditation with process improvement, that both of them go hand in hand, that you don't just come in and take an exam, but you teach the hospitals. And I know this very well because I'm the quality director for the state of Tennessee, I'm the quality director for my hospital as well. And this is a trying process, may it be in India or in America. But if in the field of medical tourism, we used to move ahead. You've talked about it being a global problem with a local solution. The issue of patient trust and perception is critically important. And that quality, that one size does not fit all. You also talked about hand washing, and I want to introduce our next speaker by giving you an example of hand washing and innovative ways that it can be done. As you well know, hand washing is a difficult task to get doctors and nurses to do. The data shows and that only 60% of hospital personnel are compliant. And so when I was in India at Narayana Hrudalaya with Dr. Devi Shetty, and we were walking through his ICU, and the neonatal ICU with little babies who had just had bypass surgery, with a tube still in their mouth, with the chest just recently cracked open. We walked, and there was something different. Everyone was quite diligent, yes. And I asked him about, what is your hand washing rate? I was straightforward. I said, we're at about 60% in US at my hospital. And he says, you know, one of the innovative solutions that we have, we recognize that it's a major problem. One of the innovative solutions that we have come up with is that every hour at our hospital, a bell rings. And you are mandatory required to wash your hands every hour. Given the fact you must wash your hands at other times when you're examining and doing, but at that hour, you're required. Now, innovative solutions, yes, healthcare workers are busy, things are going on, but what this tells me is that someone at the very high level is thinking and talking and doing something about the very elements that cause problems and infections in healthcare. We heard a perspective from the patient. We've heard a perspective from the accreditation and process improvement. Now we're going to hear a perspective, if technology permits, is going to be from a hospital in India. So our speaker is Dr. Devi Shetty. He is a renowned heart surgeon, and what really touches me is his level of compassion. He was the cardiac surgeon for Mother Teresa. He has worked tirelessly in India to make sure that healthcare can be high quality and affordable. He has brought in innovative solutions which are scalable, low cost. He himself has done over 15,000 heart surgeries. He's a graduate from Kasturba Medical College in Bangalore. He's trained at Guy's Hospital in London, and he's going to share with us his ideas and views. Dr. Shetty, can you hear us?
Manoj, can you hear me?
Yes, we can hear you clearly. Thank you.
You can see me as well?
Yes, we can see you also.
Okay. Can I start?
Yeah, tell us what the weather is like in Bangalore today.
Oh, it's very pleasant. Very, very pleasant.
Well, in Atlanta here also, we're experiencing a nice warm 70 degrees, so we're enjoying the weather here too.
Thank you. Thank you, Manoj. I just want to start my talk, first of all, thanking all of you. We believe that economy of the 21st century will be driven by healthcare industry. 20th century economy was driven by machines which address the human toil, and 21st century economy will be driven by health sector. It's because job creation is going to be the greatest challenge for the stability of the world and the society. We need industry which can create jobs for extremely skilled, semi-skilled, and unskilled people. Today there is only one industry which can create that kind of jobs, that is the healthcare industry. Global healthcare and wellness industry is a $4.5 trillion industry. In my country, IT industry gets a lot of support from the government. they don't pay income tax, they get the land virtually free. But for a $250,000 turnover in IT industry, they just create jobs for 5 to 7 people. Whereas health sector create jobs for a $250,000 turnover, about 250 people. If you are talking about inclusive growth in any developing country, health sector is the industry which can create. I just want to give an example, the economic impact of health sector. In England, everyone is complaining about the National Health Service. But interestingly, the driver of British economy is the National Health Service, and it distributes £5 billion of salary every month to 1.7 million households, from which the people can go to the supermarket, buy their food, they can educate their children, buy a new car, and pay for the mortgage. If NHS collapses in England, the economy of England will collapse. This is the very, very close association of economy, driver, and healthcare industry. 75% of the Fortune 50 companies of today are in healthcare, directly or indirectly. Coming back to my country, we believe that India will become the first country in the world to dissociate healthcare from affluence. 10 years down the line, we will have a very interesting scenario wherein we will have millions of people still living in slums with no amenities, but when they are unwell, they will have access to high-tech healthcare with dignity. How India is going to do it? It's because we produce the largest number of doctors, nurses, and medical technicians in the world. Outside US, we have the largest number of US FDA-approved drug manufacturing units. But the pitiable situation in India is that we are genetically 3 times more vulnerable for dreadful diseases like heart disease, and average age of my patients in England was 65, in India it's 45. It's the young people who die due to heart attack, and we produce about 600 to 800 children a day with the heart disease. And just give an example of what impact heart's problem has, we need to do 2.5 million heart surgeries a year. And currently, all the heart hospitals in the country put together perform about 90,000 to 100,000 heart surgeries a year. Now, please don't take pity on India, because 100 years after the first heart surgery, less than 10% of the world's population can afford heart operation. All the developments what we are talking about in healthcare reaches only 10% of the world's population. This is the population which can afford heart operation, brain operation, joint replacements, or any advanced cancer surgery. Bulk of the 90% of the world's population cannot dream of having any of those tertiary care interventions. There is a crisis in healthcare across the world. This crisis is because government feels that they can solve the health problem. We are trying to educate the government that taxpayers' money cannot pay for the healthcare. Taxpayers' money could pay for healthcare during a time when people retired at the age of 60 and they died at the age of 65. Today, people retire at the age of 60 and they celebrate 95th birthday. In that kind of a scenario, where are the taxpayers to pay for the expensive health care? We have to look at a different model of delivering health care. So 9 years ago, we convinced our state government to launch an insurance called Yashaswini Micro Health Insurance. The concept is poor people in isolation are weak, but together they are very strong. We convinced 1.7 million farmers who are members of cooperative society to contribute 11 cents per month. For 11 cents given by the farmer member, government contributed 7 cents. So this is how we manage the scheme with 1.7 million farmers. Today we have 4 million farmers who are contributing 22 cents per month. Now, you'll be wondering, how is it viable with 11 cents or 22 cents? Because statistically, when you cover a random population of 100 people, only 0.8% of the population require operation. And we pay only for the operation, and we network with 400 hospitals across the state with underutilized operating rooms, and they came forward to offer their services at a discounted price. Looking at the success of this model, many other state governments have come forward and they launched similar insurance. Now we are trying to convince the government that we have 750 million mobile phone subscribers who are spending 150 rupees per month just to speak on the mobile phone. We are trying to convince them that if they can pay another 10 rupees, we will have 750 million Indians under the health insurance scheme. We hope it will happen in the near future. Essentially, what we believe is that the world doesn't need a magic pill or a fastest scanner or a new operation. We need a mechanism to deliver what's already developed to 90% of the world's population. To prove that point, we developed a concept called Health City. The Bangalore Health City, where I am based, has 3,000 beds. We have a heart hospital with 1,000 beds, which has the infrastructure to perform surgeries in a day. We are able to break even with charging about $1,700 for every heart operation. But our target is to do the heart operation for $800. And we will reach there hopefully within 5 to 7 years when we have about 30,000 beds. When we have large number of beds, by economy of the scale, your cost goes down. Because we are doing large number of operations, our results get better. Now, how do you get that many patients? India is one of the countries, the 5 countries which has technology to put the satellite on the space. We get the satellite connection free of cost. We linked our hospital to 100 government hospitals across the country, and we have treated over 53,000 heart patients in remote locations with the Indian Space Research Organization satellite connection. And when we started liver transplant in our heart hospital, our anesthetists didn't have the experience of liver transplant. So the first 7 operations of liver transplant on babies, anesthesia was given by Children's Hospital of Philadelphia through the satellite link-up. And with their input, our anesthetists learned. Now we are doing liver transplants with outstanding outcomes. The next challenge is cost of building a hospital. A traditional 300-bed heart hospital will cost approximately $50 million in our country. Our target is to build a 300-bed hospital and equip it for $6 million. And our first pilot project is coming up in Mysore. By June this year, the first 300-bed heart hospital will be ready. It is built by a construction company called L&T, which is India's largest construction company. This hospital has air conditioning only in the operating room and the ICU, and the rest of the areas it doesn't have the air conditioning. When people live in a house which is not air conditioned, why should the hospital be air conditioned? Contrary to the popular belief, air conditioning doesn't prevent infection. It is the commonest cause of infection. We have changed the way the hospitals are built, and our next target is to build a 400-bed heart hospital for $4 million. And this hospital can be built within 4 months, because the entire hospital is prefabricated. Currently, we do dialysis for $17. Now we have tied up with one of the world's largest dialysis companies. We are planning to do the dialysis for $10. Now, how are we able to control the cost and bring down the cost to this level? Now, most of you must be thinking that it must be an Indian way of doing heart surgeries. I just want to inform you that our hospital is accredited by Joint Commission US. We follow the same norms as an American hospital, and we are able to break even with $1,700 for a heart operation. How is it possible? Because we have invested heavily on technology. Every day at 12 o'clock in the afternoon, all our senior doctors and the senior administrators get a SMS on their mobile phone with the profit and loss account of the previous day. You know exactly what is the revenue, what is the expense, what is the profit or what is the loss, and the EBITDA margin. This information comes to us on a daily basis. Our software of hospital management system is based on the ERP solution from Oracle. It is on the cloud, and we have 14 hospitals in 11 cities. We can get the real-time information anytime we want. If a hospital gets a profit and loss account at the end of the month, it is a post-mortem report. You can't do anything about the outcomes. Whereas if you get the profit and loss account on a daily basis, it gives you the diagnosis and you can take remedial measures. We strongly believe that charity is not scalable, but good business concepts are scalable. And this is what we are trying to do. Hospitals today can transform the country's economy and the entire society. As an organization, we have over 12,000 employees across the country. Over 94% of our employees are women. As an unwritten policy, we give jobs primarily for the women. The reason is, if I have the job of cleaning the floor, I give the job to the man and give him 4,000 rupees salary. He will spend 2,000 rupees on himself, and another 2,000 rupees goes to the family's welfare. Whereas if I give the job to his wife and give her 4,000 rupees salary, she will spend the entire 4,000 rupees on the family's welfare. A woman who comes from a lower socio-economic strata, when she is employed, she becomes an empowered woman who will bring up confident children, who will build a great nation. This is the power of health sector. We believe that there is going to be a crisis in the manpower requirement in healthcare. So we launched a health insurance, we launched a scholarship program with the intention to bring 2,000 children from villages of India and make them as doctors. These children should come into us when they are 13 years old, that they will become doctors. And we give them a $10 scholarship per month. We mentor them, and these children work very hard. They get into the medical college, and we guide them. Essentially, all we are trying to do is to change the way the healthcare is delivered. So healthcare not only makes a country a healthy country, it will also drive the economy of the country. Thank you very much. Thanks a lot for giving me this opportunity to participate in this conference. Thank you.
So, Devi, do you have time for some questions?
Yes, please. Yes.
So I'm going to ask the audience, and we'll begin the panel conversation. What's amazing is what you have been able to do at your hospital, provide high quality at such low cost. Tell us, what are the 3 or 4 areas of success that has led to this? Were you able to get that?
No, Manoj, you went off. Again, you have come back.
Oh, okay.
The question.
Sure. I said you've been able to tell us that you've been able to deliver. You've been able to deliver very high quality at such low cost. And the question is, what are the 2 or 3 things that you have done that has led to this success?
The most important thing what we have done is to control the cost. We believe that unless we know exactly how much money is coming and how much money is going on a real-time basis, you can never offer affordable healthcare. If a solution is not affordable, it is not a solution. For us, the effort is constantly driving down the cost. And second thing what we have done is a very, very meticulous attention to quality. I'll give a simple example how attention to quality makes a difference. Across the world, incidence of pressure sore following heart operation is in the range of 9% to 40%. In our hospital, the incidence of bed sore following heart operation is virtually 0%. How we addressed it? Because we have a mortality morbidity meeting every Thursday, and we made our nursing superintendent in charge of the strategy to prevent bed sore. And she was given the freedom to do whatever she wants, but we don't want to see a bed sore following heart operation. And every Thursday morning, she should come and face all the 45 surgeons and the anesthetists and tell us whether there was a bed sore or not. Just to save the embarrassment, she will go to any extent to make sure there are no bed sore. So essentially what we have done is to address each and everything what was considered as impossible by giving the freedom to people and take action as long as they give us the outcome. So quality and money, if we look at these 2 issues, everything else becomes a minor detail.
Thank you. I want to add to that conversation. We heard Willie Bearden talk earlier. When he went to his cardiologist and asked him how much a procedure would cost, what did the cardiologist have to do?
Send the nurse.
Send the nurse out. And I'm guilty of the same thing. If you ask me as a patient, how much will this procedure cost? I don't know. And the reason is because the costs vary. How much a Medicare charge or the payment will be, what a private insurance, what Medicaid. The complexity is so huge in the payment system in America that it's just mind-boggling. And so I appreciate the answer tremendously that the cost and the quality, which is what we call value. Value is cost over quality, and that's where we are heading. And I think that's where I've sort of really heard you talk about is trying to bring value to our healthcare system. Thoughts, comments, questions for all of any of our panelists, please. Yes.
I'm interested in the difference between what a physician is paid in India and what they're paid here. And could we use as an example the surgeon who helped Mr. Bearden? What was his fee for doing that, and what would it have been for a typical heart surgeon in this country?
Sure.
David, can you hear the question at all? Okay.
Yeah.
I'll just repeat the question, and I'll have the panelists here also say it. The question was, how much is a physician paid in India compared to what they're paid in America, and to sort of relate with that, and I'll have a comment on this too. In fact, I'm working on a piece for the Washington Post, which is talking about income inequality within physicians in America. So would you like to address that question of physician income there, and then if the panelists also want to make a comment?
First of all, Manoj, the cost of living in India is much, much less than cost of living in the US. A physician earns a sufficient amount of money to own his own 4-bedroom house, have at least 2-3 cars, have 1 or 2 drivers and 2-3 maids at home to care for his children. So essentially everything what is required he can have. And generally I feel, I mean, Manoj, you must be knowing more than I do. I guess the physicians earn in this country about 30% of what, 30 to 40% of what a senior physician can earn in America. I like to stand corrected.
Yeah. No, yeah. I think probably the physician income in America is significantly higher, and it varies tremendously. And just to sort of put it into perspective, a proceduralist in U.S. On average will make over $400,000. A primary care doctor on average will make less than $200,000. And if you want to talk about income inequality, a gastroenterologist in U.S., top 10% make over $715,000, whereas the bottom 10% of primary care doctors in America make less than $100,000. So the income inequality is huge. But your point well taken that there is the physicians in India are not as if they're getting tremendously underpaid, but they're sufficiently poor to have a good lifestyle and a respectable income as well. Would you like to comment, Willie, on your physician and the salaries that, and what you paid for them and so forth?
Yeah, I mean, I would like to know from my $9,000 that I paid, you know, what did the doctor get, and how is that? It was a very nice, and I want to apologize. I forgot to show you the photographs that I had of my room, and hopefully in a few minutes I'll be able to just kind of run through those, show you what my room looked like, what the hospital looked like, and all that in Bangalore. I would like to know, you know, what my doctor makes, because I just can't imagine why it would cost $9,000 here and $250 here. It just.
I think I have another comment, is that if you take the ratio that we mentioned, it does not explain this incredible difference between 9,000 and 300,000.
Right. It's not the physician income which is determining the cost difference.
So even if you factor that you have a similar reduction in cost of nurses, etc., one thing that I think would work more to the Indian system is the fact that the healthcare insurance is not as pervasive. And when I say pervasive, the pervasive cost of healthcare here in the U.S. is almost completely divorced from reality, in a sense. The gap between, let's say, primary care and specialists, maybe not to the extent that Manoj said, but it is almost in every country in Europe, with several exceptions. In some countries they have more, some less. But they have it's not 7 times, it may be 2 times, maybe 50% more, but definitely not the gap that you have in the US. And the reason for it is probably because of the healthcare insurance, nothing else. So could you explain that a little more?
Yeah, what does that mean?
Yeah.
Here's the last statement.
Sorry?
Explain the reason for the.
What do you mean by that? Well, the way, when you have a system that is not, you do not know what is the cost. That means that you have almost a cost plus system. You're based on reimbursement rather than based on the real cost. When you have something that there's so many inefficiencies and anomalies in it, even the fact that you don't know how much is a true cost. How much does that, why should it be 300 for some and 100,000 for another? That means that you have incredible inefficiencies, and I'm saying it from an engineering perspective without really delving of why. But when you look at 3,000 payers in the US, that each one had probably a different system, even if you read in the papers that 30% of the cost goes to just processing of claims, somebody is being fed from this. How? I don't know. But it is all it's the realm of how physicians, how you treated, you looked at physician, this whole incredible increase in cost or in price or fees the physician made is only something from the 70s, maybe late 70s, 80s. Because if you look at the 50s, if you look at before CMSK came on board, before this whole health insurance, you did not have that much of a gap. I mean, we looked at some statistics. You did not have that much of a gap. I mean, it's outside of my discussion. So I think we can.
Yeah.
But we have a lot of statistics.
Do we have a table of comparative cost for the doctor, the nurses, the medical room, the processing of claims? Is there
Yes,
a table to
there is. The Commonwealth Fund, which is a nonprofit organization, has done numerous comparisons between nations, industrializations and U.S. in looking at healthcare costs, and our healthcare costs are significantly higher, and the quality does not. It's where is the information?
No, where is the difference between 9,000 and 250? I'm missing 241,000.
That's probably the $60 billion.
Yes.
64
But I'd also like to ask, I thought that when I was, like everybody I saw in India in my hospital was a doctor. Like it seemed like there were like many more doctors there than there are here. And I was telling people, I said, well, in the U.S. these days you really can't get a doctor. A lot of doctors won't take new patients. If you happen to find somebody who will take you on, it's going to be 3 weeks. And everybody's looking at it like, really? Like 3 weeks? And oh yeah, and you'll get to the doctor's office. You'll sit sometimes for 3 and 4 hours. And that was just, that was just one of those things like people were like, I can't.
That doesn't break the question with 50 MBAs in the room.
Yeah.
This is an answerable question.
Venkat, do you want to address that, and then I'll address it as well?
I think, again, this is my opinion. I think there are three issues that are different in terms of cost between India and the United States. First, we spoke about physician costs. It's not just physician salary, it's the ancillary salaries, which are much much lower in India. That's one thing. Second, they deal with large volumes. And third is the issue of choice. Regardless of how much insurance is available, choice is much more limited in India compared to here. So all these three, when you multiply them, explains a lot of the cost. As cost of living in India goes up, these costs are going to go up.
And there's also one other difference. There's between charges and cost. So when a hospital says that they're going to charge you $300,000, actually, if you go to them and say, look, I don't have insurance, what can you do? Or what will Medicare pay, or what will private insurance pay? They come down nearly 50%.
You hope.
You hope. Yeah. But in many ways, it's a game that is played very often in the healthcare arena. So other questions and comments, and then yes.
Yehuda mentioned that healthcare insurance is a large part of the cost base.
Yes.
In the U.S. Dr. Shetty mentioned that they do have some kind of an insurance scheme in Karnataka.
Yeah.
And so perhaps he could tell us what is the difference between medical insurance costs for physicians in India versus why it translates into such a high premium in the case of the U.S.
So, Devi Shetty, we had a question here, and I'm going to repeat it, okay?
Yeah.
Okay. So the question was, we have health insurance in America, and you're putting together a scheme in India. And the question is, why are the premiums in America so much significantly higher than what you're able to deliver or to offer in India? Give us sort of a big picture of that.
See, the Manoj, we believe that health insurance companies are like
travel agents, it's a matter of time before they lose their significance. The reason being, health insurance companies do not give any value additions to the entire healthcare delivery. All they do is aggregation. At a time when there was no internet, there was no way of bringing people together, they played a very significant role. Today with the internet, mobile phone, we can bring people together without any problems. So we have convinced the government that government has a role to collect the money from people and act like an insurer without charging any fees. There is no, if 100 rupees is collected, 100 rupees is paid for the healthcare. So there is no management cost, hardly any management cost. Whereas if you have a listed health insurance company, they will naturally want to take their margin. In this industry, if the pharmaceutical industry is listed, they want to make money. If health insurance company is listed, they want to make money. Hospitals are listed, they want to make money. Where is the money coming from? So ultimately, what we feel is that government across the world cannot offer free healthcare with taxpayers' money. But they can be a not-for-profit health insurance agency which will collect the premium from millions and millions of people and distribute the money to the hospital where the procedure is done without really charging any managerial fees. That is the reason why we have been able to keep the premium very, very low.
Okay, thank you. Other questions? Ravi, did you have a question or?
No, it's just very interesting for me to listen to this discussion. So I'm a proceduralist here, but I'm in full disclosure on staff and Emory, so I don't know dollars I did. Several thoughts. One, when you talk about costs and charges in the medical system, the reason your doctor doesn't know what it costs is because the doctor knows what his or her professional fees are. But there's a hard line in this country between the doctor's charges and the hospital charges. And there's it's the separation of church and state in the truest sense of the word. I can tell you what my fee will be, but I can't tell you what your charge will be because that's controlled by the technical fees, the nurses, the rooms, and everything else that the hospital controls. So you can't get your bottom line number. That's not the physician's issue. The professional fees are very straightforward. There's a chart you can go to and you can look it up and you can know exactly what the doctor is going to charge, what the doctor is going to get paid for every single thing, from your consultation to your heart surgery. That's straightforward. The complex part is the technical fee portion, which is a mystery to physicians and to hospitals, and is kept that way specifically so that the doctors are not in control of the overall cost. Okay, so that's very important for the public to realize, and the economics of it are complicated by that. You don't deal with one number, you deal with two separate numbers, and the second number is obscure. So that's interesting. But the difference in the 9,000 and 300,000, I would argue, would be a provocative statement. Where is that money going? I would urge the American public to look at themselves. They're the true drivers of healthcare costs. It's not physicians, it's not hospitals. The analogy that I use is as follows. If you were to walk into a Porsche dealership right now and say, I want that Porsche, and they'd say it's $100,000, and you say, well, I only got $10,000, they say, well, you can't have that. But if you walk into a hospital today and you say, I want $300,000 worth of heart surgery because I'm having chest pain, and I only have $10,000, they say, sure, come this way. So your $300,000 are going to pay for lots and lots and lots of people who want Porsches but can't afford it.
Good.
And so as a society, we need to decide whether we're going to be utilitarians or whether we're going to be rights-based. It's the oldest dilemma in America that's been going on for 300 years.
Yeah.
And the American public wants it both ways.
Yeah.
They want their 90-year-old grandma to get every test and procedure done to man known for an extra 3 months of life. Don't give it to someone else's grandma, but for my grandma, I want it all done.
Yeah.
And that's the problem. We want everything, but no one wants to pay for it.
Yeah, and I think you put it very well. I think that's very helpful. Yehuda and then
Porsche. I mean, we are diverging into an area which is so fascinating. Maybe to the lunchtime is something. But I can tell you, CMS estimates that between 18 to 20% of its expenditure is fraud. You talk about almost $1 trillion budget. You talk about $200 billion only to fraud. Then there is even a to me, is a more chilling statistic, that the estimate of what's called the moral liability. The moral liability or moral hazard, that's another euphemism, is about 45%. Moral hazard means that you are not fraudulent, but you can sway the coding and the billing to do something. If you talk about 45, let's say even 30%, you talk about $300 billion. And then you expect everything. The expectation, I lived in 5-6 countries, and I did not grow up in this. It's all about expectation. You expect everything, and then you want everything to get. And anytime you talk about changing the expectation, the political pressure starts, pulling the plug on grandma, and death panels and all this. Somebody has to have a much more robust discussion that starts at a very early age in life. What is quality of life? What is end of life? How do you do that? It's not for us to solve it, but it's society as a whole need to address it. And until you address it, I don't think that we will have any solution.
Yeah. We have a few more minutes. I'll take a couple of questions and comments. Yeah.
This question, I'll steer away from the cost aspect into the education portion. So my work is in cross-cultural consulting and training, and I train a lot of expats that come over to the U.S. And in almost every case, I had to add a section of my program that was about healthcare, because not only did these expats have no clue what their new U.S. healthcare policy was about, but none of their U.S. counterparts or HR department or anything also knew. And so I would have to explain to them what co-insurance meant and what the deductible was and what all of these terms, and how they had to have some money set aside in their savings if they had to end up paying the deductible. So my question is, I guess probably to Dr. Shetty, that are there some elements of what's being done in India that might help us, and vice versa perhaps, be better about the education portion of letting people know what their health insurance actually consists of, including the cost?
Sure. Devi, there was a question here. I'm going to repeat it. Can you hear me?
Please, yes.
Yeah. So the question was, there are many expats, people coming from India, for example, have very little knowledge about the insurance and co-payments and so forth. Are you finding that people in India are beginning to understand that vocabulary better now? Or what's the education level of the Indian public about health insurance?
It's, Manoj, it's very, very poor. Even today, people don't understand the concept of health insurance. I'll give an example. One of my favorite pastime is to spend the weekend in villages trying to educate people to contribute for the health insurance. And I always tell them the story that every month you pay 11 cents and you need a heart operation or a brain operation, kidney operation, it will be done free of cost. Or their face lights up, they say, that's very good. Then after a while, she will look at my face and say, okay, if I don't get the heart operation or a brain operation done, will you return my 11 cents? So this is the knowledge they have about the health insurance, but then we have to start somewhere and start educating them.
Yes, great. Thank you. That's a great story. I have a question? Yeah.
I just had a quick follow-up to that statement. What does 11 cents mean to someone in this program? What's the relative spending power of that money?
So the question is, what does the 11 cents mean to, in terms of the spending power of a person that is buying that level of insurance?
See, for people to accept this insurance, the money should be so small. So we peg 11 cents is the price of one packet of country cigarette. That's a BD. You know, Manoj, they smoke those BDs.
Yes.
One packet
I didn't smoke them, but they look for the audience here. I'll tell you what a BD is. You know, if you've smoked a joint, no, not joint. Yeah, but it's like a joint. It looks like a joint. You sort of wrap it up, but instead of wrapping it up in paper, what you take a BD and it's wrapped up in what type of leaf do they use? It's tobacco leaf.
I really don't know. It's just inside that it's tobacco. Yeah.
It's the back of the leaf itself. It's a different leaf, yes. So I forgot what we were talking about.
The packet of BD costs 11 cents.
Yeah.
So we keep the premium of health insurance 11 cents, telling them that you don't smoke for 1 day. With that money, you buy your health insurance.
Yeah.
So this is the way to sell the insurance.
Okay. All right, we'll finish up with the last question, and yes.
Actually, I have two questions.
Absolutely.
The first one is to Mr. Bearden. Are you going to do a documentary film on this experience that you had?
You know, I am. I really do want to do that. I've gotten so busy this year. I was going to try to go back to India just kind of for a checkup, even though I don't really need to. But I'd like to go back and take a camera and tell my story as I kind of walk back through this thing. Because like I say, Dr. Javali is my Facebook friend. My nurse is my Facebook friend. And so, you know, I feel like there's definitely something there, and I think I maybe have a point of view and can talk about this and maybe get the conversation spun up a little higher, hopefully.
Well,
So yeah, I'd like to.
Related to that, you know, it costs you $9,000 for something that would have cost you $250,000 to $300,000 here.
Right.
Is there any structured program for people who participate in medical tourism to actually pay forward? That is, to contribute the equivalent, let's say, of what covered your costs were $9,000 to some charitable organization in India, where that can then be resurfaces for other people who might need this kind
I'd
of
like to find out about that, and I hope there is something. But like I say, the people who contacted me about going over, and they're going over in a few weeks, I'm going to pick up their hotel, you know, and that's probably be $500 or $600. But I feel like that's kind of my responsibility, and yeah, I would definitely put money into something like that.
So I'll say this, Willie and I had coffee at Starbucks a couple of days ago, and we had Oscar fever, and so that's a great idea. Documentary, yeah. There's a category for short documentaries, really. There's a scope for all that. Well, I think we should be finishing up. So much tremendous energy. I've learned a lot, Dr. Shetty, Devi, thank you for being with us. And, you know, this may have been a talk about medical tourism at one end, but it was really a talk about our healthcare system as well, looking ourselves in the mirror and seeing what our health system is about. And really, I think that's what the Emerging India Summit is about. It's not about just one nation that's coming out in a new area, field of medical tourism. It's about how we all improve, how we all begin to gather those innovative ideas, those leapfrog approaches to being better and more productive human beings. So thank you very much, and have a wonderful day.
The preceding program is copyrighted by Emory University.